Hey everybody, welcome back. I'm Matt Brown. This is Dental Unfiltered. I'm here with my normal co-host Andrew Vallo, and we have Dr. Sausha with us today. Today, guys, we're going to talk about some really awesome stuff. This is going to be a really exciting episode. I met Sausha a few weeks ago, and I really enjoyed a video call with him. This episode is really exciting for me on a couple levels. First is we're going to talk a little about digital workflow and kind of how that works. And for me, what that's really exciting is me being an amputee. When I go get a new prosthetic for my leg, they scan my leg, they make this mold, and they make this awesome carbon fiber thing that fits me perfectly. And really, this is the mouth version of that. And we live in like a Star Trek world today where you can scan someone's mouth, pop out the appliance you need a room away, and control the whole quality from design to scan to delivery. And
Matt,
that level of patient
you know what's crazy? The very first time. So like one of the major technologies that I like to leverage in my office, I go around like the country lecturing on it, so I'm definitely biased towards 3D printers.
Yeah.
The very first time I came like in access, I saw a 3D printer, a desktop one, like a small. Yeah. It was in the library at dental school, and it looked cool. Like the machine's got like neon lights coming from like every freaking direction. It looks like it dropped down from space, and it had like a cool like red and green color printing. It was a hand. It was a prosthetic hand. It was a prosthetic hand. And I walked up and I was like, hey, I went to the library tech and they were like, oh, this is the occupational therapist. They're cranking these out for kids. And they had like kids who had, amputated or never had a hand. They're developing these like prosthetic limbs with like Iron Man symbols on them, different like of the Marvel characters. I thought it was the coolest thing. I was like, oh, wow, like I don't want to like cut your production line. This is awesome. They're like, no. There's time. You can use it. So that was actually the very first time I saw prosthetic limbs.
We live in a really great world for this now. And it's amazing. And the fact that it's in dental now, this would be a really long process or a hard process years and years ago. But now it's like, it's so accessible. If you have the right amount of clinical treatment to justify the cost as equipment, you can create a high, awesome patient experience and standard of care that you control as the practitioner the whole way. That is so exciting to me.
And I'll tell you, 3D printing is one of those quick ROI instruments. Quick.
So real quick, before we get really deep into that, just real quick, why don't the two of you kind of recap a little bit about your relationship and your practice and kind of how you two came together, and then we'll get right into digital workflow.
It was a bowl of spaghetti. Yeah, go ahead.
Oh man. Well, Sausha, I'm glad we finally got you on here, guys. For you guys listening, you've heard me and Matt talking for almost the last year here. And you've heard me mention, a few times my partner at the implant office. Well, this is my partner, Dr. Sausha Toghranegar. If you can spell his last name, you win a prize. So I met Sausha. He runs these dental show and tells. They're basically more fun dental CE events geared towards younger dentists. That we usually would
It's the future of dental CE. Let's be honest.
The future of dental CE. Yeah, I'm underselling it. Sasha's a humble guy, but he'd do these open bars, and so some dentists I had met in the area. I just moved to Tampa. Some dentists I had met in the area had brought me, to this thing, and he knew I was working on this startup, and I met Sausha there, and it turns out we were pretty much neighbors. We went to the same gym, and so we kind of got to know each other a little bit. And then, at one point in time, we're at the gym, and I just mentioned to him, I said, you do all these implant procedures in this, higher end specialist office, but like there's such a high demand, especially here in Florida. We've got a lot of retirees down here, a lot of people with missing teeth, a lot of people that want these full arch implant, treatments, but they're pretty expensive. Costs can be prohibitive. There's not a whole lot of options out there that are offering a competitively priced, full arch implant option. What if we put our heads together? I know the business side, I know the marketing side. I don't know the first thing about placing dental implants because I've never placed one in my life, but you've got that down pat. You've got the technology side. Like, what if we figured out a way to help control our costs, still provide, a stellar product and, offer it more to the masses? And I kind of figured, he might think it was intriguing, but he was like, yeah, I love it. Let's do it. And that's about what I remember. I think it was about like a month later we signed the lease, and 2 or 3 months later as we opened that startup implant practice.
It was super quick because you told me, like, I met this doc who does implants. We go to the gym, and all of a sudden you were opening a practice together. It was like weeks. It really was.
The thing is, though, for me, like, when I was like, are we moving too fast feeling in a relationship? I didn't have that at all. I was like, this is perfect speed. I loved it. But my side of the story, Andrew, my side.
Yeah. Good. Tell your side.
So, but yeah, my show and tells. I do remember, you know, I'm a periodontist, so I need referring dentists. So for me, those events when I meet another doctor, a new doctor, I'm like, "Ooh, you're in town." So I hyper focus in on him. So when I saw him in the gym, across the gym, I'm like, oh no, there he is. All right, play it cool, do a tricep rep right next to him. Hey, what's up, man? and then you know, then we became friends. COVID hit. We kind of got locked in to having to stay because we lived close to each other. So at that point, living close to each other during COVID, when like that deep lockdown time, we ended up hanging out a lot. And I saw him growing his office, and I saw the quick success he was having, and I was like, man, this guy's got some business acumen when it comes to running dental offices. And I mean, I've always been very nerdy and like loving every aspect of dentistry, but I did like blow past any kind of understanding the business models that I could potentially be playing with. I didn't have a good grasp of that, but I love 3D printing and all the digital tech, and I was leveraging it so much. And during that era, that's when the whole concept of like doing these full arch restorations started to become really digital, like almost fully digital, with, you know, the way they do these photogrammetry scans and the 3D printing. And I was getting into it just as it was like, I was like an early adopter on doing it that way. And just when I was doing that, I was kind of running some of the numbers back, and I'm like, man, we cut our costs down by doing these so much, you know. And I was in situations where I can't control the cost to the patients. And I was like, man, I feel bad because I do feel like I'm seeing a lot of patients that could benefit from it, and I'm letting them down.
So, real quick, you were working for someone else. You had the
Yeah.
digital stuff in place, and there were patients where like they couldn't do 40,000, but they could do 29, and you know you could have done that, but you couldn't because of where you were working.
Oh no, and I'll tell you, sometimes I did. I would tell the patient it's going to be this much, and I mean the front desk, the offices I'm working, they'd come and slap me in the hand. They'd be like, "What are you doing, man?" And I'm like, "Look, like I just brought the cost down. Like, let's do these procedures. I want to do more of them. You can only get proficient by doing more of them, you know. And these patients, they deserve it. Otherwise, they think all they're going to be able to get is an overdenture or nothing, you know, and they're not going to get anything. Or that, I mean, at that stage, it was there weren't at like the amount of people doing full arch dentistry or full arch implant dentistry isn't as much as it is now. It grew like fire. This concept helped, I'll tell you that, but that was brewing in my head. I actually had like a conversation with my dad, like near the time you brought it up to me. And I was like, all right, if we like brought certain costs down within reason, we could meet a price point that I thought would be that would open up the floodgates to get patients to start doing these procedures more. And then Andrew comes to me in the gym.
You already thinking about where volume meets margin and also meets case acceptance. You were thinking about like, I get more case acceptance, I can do more volume, the margin meets, and then you collided with Andrew.
Yeah, it was like the perfect. That's why I didn't hesitate, because I was like, wait, he literally is bringing this up when it's like fresh on my conscience, like it's boiling at the top of my brain, and he hits me with that, and I'm like, yes.
It was really easy to talk to Sausha at the gym because back then he didn't wear headphones, so he went to the gym. So I don't know if you guys have heard about these people that they're calling it raw dogging it on flights. It's this new trend. It's not as dirty as it sounds, but it's this new trend where people are going on a flight and they're having no entertainment, no headphones, no music, no books.
I've seen those.
No water, no snacks, no drinks. And they're trying to set new PRs for how long they can do it. You know, I just did a 9-hour flight, raw dog, nothing. So that was like interesting. I would never do that. I'm not a masochist. You know, I want to watch a movie or, you know, whatever on my flight.
Honestly, I would just forget to charge my headphones. But it worked out for the best. You know, things happen for a reason. But
I noticed.
You know what? Now I wear headphones to the gym, and I'm listening to your guys' podcast.
That's awesome. Well, and I noticed that you look like you've gotten stronger since you started wearing headphones. So I think that was probably my best contribution to you. You know, outside of this whole office idea. But no, it's really cool, guys, because not only is it a very great business model, because as we've talked about, our newest implant startup set a new record, collecting over $200,000 in our first 30 days open, which still blows my mind. But we're able to help a lot of people out too. So it really is a win-win. We are providing awesome dentistry with really great super GPs that are amazing surgeons, Sausha, is watching over them kind of as our clinical director, just making sure that everything's going well. But it's been going extremely well, helping a lot of people get their smile back, get their function back, and having a very profitable business, at the meantime. So it wasn't always that way. Going back to the origin, for those of you that haven't heard the story, the office where we actually started our first implant office, it was a old dentist office. When I say old, I mean the dentist had been there since like the 60s, and it looked and smelled like that. So when I first came across the opportunity, I was a little bit hesitant about it. I didn't really think that we could turn that into a successful practice, but we did, and we did without a whole lot of funding behind us. Sausha and I were actually in that office. We spent a couple days. If you ever seen the show Hoarders, that's basically what it looked like. So, everything was left in the office. Most of it needed to be thrown away. And Sausha and I spent hours just, with our sleeves rolled up, cleaning out all of this crazy old dental stuff. Some of it, I had no idea what it even was. I mean, it probably belonged in like a dental museum or something.
Oh, yeah. Yeah, I was like, yeah, the giant jar of mayo was the thing that threw me the most off. That was in the lab.
It was interesting because I went there after you guys had opened, and I spent a day there in the practice. And Andrew's like, "Oh, we updated it and we remodeled a little bit." And I walked in, and I was like, I feel like I walked into a time capsule a little bit after you guys opened it. So like, I can't imagine what it was like when you guys first got your hands on it. Because when I walked in, the first thing I said to your brother Zach was like, "This place is a little bit dated, huh?" He goes, "It's way better than it was."
Yeah.
That's what Zach said to me, and I was like, I couldn't imagine what it was then.
Yeah, we should have done one of those like walkthroughs and then cut to the new version of it, because then it would have hit you. It was a stark contrast.
So looking at it from my point of view, Energize has 100 and whatever practices, and then we look at all the data. You guys took this time capsule of a practice, dated to the max, didn't have anything modern, overnight turned it around, and you turned it into a $2 million plus practice a year on the stuff that we're all talking about right now. Like literally, like you guys, like docs go, they do a startup, and they spend $400,000, get state of the art everything. They think if you build it, they will come. And you guys did the opposite. You guys found this relic and rejuvenated it into a $2 million practice, which is most people's dreams. And you guys probably did it on like a shoestring budget.
Yeah, I think it had a lot, and this is where the tech comes in. I feel like, yeah, the building itself, we did a great job making it look but the tech, I mean, that's it. We spent, as far as like figuring out what we actually needed to buy for the office, the tech that we picked was the tech we needed, and that was all we needed. So we were very careful about choosing what we picked and bought, because we knew we were going to use it.
We spent money on things that were going to turn ROI. So, our initial loan to get that practice going was $300,000. So for a startup, pretty low. We did not have to do a full build out. It was already built out for 5 operatories. We did have to buy some new equipment, and we did do some cosmetic construction. So, we updated the bathrooms and the flooring, and we took out just like the old shag carpeting they had from the 60s or 70s, and the full wall mirrors. And, they had like a jungle of these like weird potted plants and stuff in the waiting room we took out. So we did do some of that stuff. But again, we spent money on 3D printers. We spent money on, scanners, things that could, both make our processes more efficient, but also more cost effective. And the other thing we spent money on, guys, something we always talk about, was marketing. So, that we would never, so that practice, our first 12 months open, we collected $1.5 million. All we do is dental implants. There's no hygiene. There's no restorative. There's one doctor. He's there about 3.5 days a week seeing patients. So pretty awesome start for our first time, trying the implant office, and our new one in Riverview, should surpass that for sure in its first 12 months open. So.
The things that we chose, as far as like technology wise, the trinity that I need to make these full arch cases work: cone beam.
Yeah, cone beam's foundation is the beginning. You have to have a CBCT. If you don't have it, you're not doing this work.
It's just the new X-ray machine. Cone beams, you need them for so many different reasons. Intraoral scanners. And when I go around and lecture, it's a young lecturer. When I go and hit the lecture circuit, I used to be timid about it, but now I just say it. I'm like, if you don't have an intraoral scanner in your office, give me your retirement party invitation, please.
Yeah, I agree.
And then the 3D printer. And the 3D printer, we could debate that one a little bit more, but for the sake of implant dentistry and full arch dentistry, it's gotten to the point where the ROI on it is like it comes back within a month sometimes. For me at this stage, it's a week. I'm getting my ROI. I could buy a new printer every week and make sense for me. The relative cost of a 3D printer compared to an intraoral scanner and a cone beam, it's the cheapest by miles. And what it can produce for you, the lab costs it would save you, the time it saves you is significant, and it brings back that potential income right away. 3D printers are different. You don't experience as much or interact with 3D printers as much in the boutique.
No, at the general offices, we don't have one. And, I keep there at this point, they're so affordable. I keep toying with the idea of getting one. I don't think it would have the same level of value that it does at our implant offices. But to your point, how long would it take to return value? I'm sure it wouldn't be that long. So
I'll tell you, it's about creating a system for it too. Like once you get it rolling, once you delegate the jobs for it, there's so many different companies out there. And I'll tell you, there's different gradations. There's companies that are like less than $1,000 for a printer. You have to be a little bit more hands-on about it. You got to know a little bit more like printer technology. You have to understand the technology better, but you can buy it for a cheaper rate. And then there's the middle tier, which is, I'll tell you, most of them are in that middle tier and they're under 10,000. And they're pretty easy to delegate. They have good support softwares and they've got good support systems. So if it goes down, you just call them. Patterson sometimes. Anyone who actually sells them will come out and fix it for you. Then there's like really high-end printers. We're talking like 40,000 and plus. Those are going to be like your lab technicians. They probably might have more use for those kind of printers. And I'll tell you, I have one. I still like my middle tier printer better, even for those purposes. Unless you're like a lab cranking things out, talking like models and anything you could possibly do with a printer, but mostly creating a ton of models, which labs do. We don't.
So I have a question. So I'm a GP. I started doing implants. I went to a CE course. I want to go the direction that you two went with these practices. That's what I want to do. What is the first word of advice or first like this is the beginning? Like I knew the cone beam is the first thing you need. But if I was sitting down with you for lunch, I was like, hey man, I want to go this direction, and I'm gonna become a super GP and do this. What is the first like thing you tell me and direction you send me in?
First direction, and you've taken all the courses.
I've done my implant courses. I've placed a few implants now. Now it's time to implement and execute my practice.
So when you're doing the full arch cases, let's say they haven't done full arch cases.
Yeah.
As easy as they can. I mean, I don't think anyone actually considers them easy, but you don't want to lose the confidence in them because they can't. If you're not, careful, you can run into tricky cases, and they are hard cases to have a plan B for. Because they're end game scenarios. I mean, you're losing all the teeth. A lot of times you're removing bone. That's it. So if you're up the creek, you're really up the creek. So it's pick your first few cases carefully.
Okay.
Get your system down. You figure out all the intricate components that you need to the fundamentals.
Yeah.
Then you can start dealing with little problems here and there. See what I'm saying? Versus just jumping in and being like, I blew up this case. And it's your first one or two cases, you're going to freak out. And I see it all the time. I see a lot of doctors who gear up to be implant offices or introduce implants. Let's say they do everything. They'll jump into cases, crash, and then freak out and pull out and have this like motor building up dust in the corner, having a little stock of implants. And then, honestly, they become some of my best referrers because they understand implant dentistry, but they're very fearful of it. And so I coach a lot of dentists to place implants, and I tell them, like, single implant dentistry is not too hard. So I'm like, just pick some easy cases. Make sure you got like the basic fundamentals down. Open up, chapter by chapter. Add something slightly more difficult every time. Get to that point. Don't just jump in. I mean, that's how they teach you most things,
I think it's just like any other procedure. If you're just kind of getting your feet wet with molar endo, it's case selection. You should be looking for those cases that look straightforward, easier patient. They're able to open wide enough that you've got visibility in there. It's probably a first molar instead of a second. You can see all the canals on the x-rays.
I mean, your Invisalign cases, you tackling the hardest ones first?
No, absolutely not. So same thing, you build yourself up. I mean, at this point in time with Invisalign, I feel comfortable treating literally anyone that walks through the door. But when I first started doing Invisalign, that was not the case. I was selecting cases that were more straightforward. And as you learn, you get more comfortable in your skill level, your confidence builds up. That's when you start tackling the trickier cases. So I do think if you're starting out in full arches, one, you should have a good relationship with a specialist or, another doctor that can help you out if you do get yourself in trouble. But you also need the first thing you need to learn is the case selection. You need to learn how to diagnose cases and know cases that are going to be more straightforward for you to take on, and get some of those under your belt and build that confidence before you try to move on to the more difficult cases.
I'll tell you, mentorship helps a lot with that. Like I work with a lot of dentists. They'll text me, email me, Instagram me cases and be like, hey, what do you think about this? And I'll talk them through. I was like, this is where my head's at. I'm not doing the case with them. I'm not even in the same state as them, but I'm trying to help them out. And I feel like that helps them understand the cases a little bit better. That goes with like anything you're learning. Just makes sense. Especially if, like I said, end game scenarios with these full arch cases, it's even more important. You do take those baby steps.
Well, and I think, part of the reason why this has been such a great experience for us is because we found great doctors who, know their skill level and, take on cases they can handle, because otherwise you'd have a lot more work on your plate trying to clean things.
Oh, no, for sure. And I am not of the category that like it has to be a specialist. Trust me, I know specialists that I don't think should be doing surgery. And I know general dentists that are doing surgery that shouldn't be doing, it has nothing to do. It has to do with the individual and their potential. And I think everyone doesn't have the potential. I might be in the few that think that, but as a guy who's gone around and taught different people, and I can tell like, okay, you got it. Or, hey, you don't got it. And it's fewer in that category, but it exists. And trust me, they go out there and they do, there's people who probably shouldn't be doing Invisalign, but they're doing it. They exist. They're out there. But it doesn't have to be that. It just has to be someone who is competent. And for us, when we're looking for the doctors who want to work with us, when I'm vetting them, I am seeing how dedicated they are to that procedure, their knowledge of that procedure, how quick are they able to diagnose if they're gonna crash or not. I'm trying to say, hey, do you have any cases? If you don't, that can be a red flag. It's not the end of the world. Then I want to see what their other implant dentistry experience is. So we are kind of going through that process. I have them show me cases and then also talk through the cases with me. And then I kind of normally prompt them to say, what would you want to do? What would you have done better? Like, what would you like to improve? Because I will show you cases of mine that look perfect. And I'll be like, well, I don't like this about it. And I think that's the key to getting good at something, is knowing, even if you think, like, even if it looks good, can you pick out the small little nuances of wrong in your own work? I think that's a key component of becoming good, or almost, a master of your craft.
I love it, man. So I think this is an opportune time, and this is something we normally do more at the end of an episode, but just based on where the conversation's at, I think this is an opportune time for me to let you listeners know, if you're a dentist that loves doing full arches, you're already doing them, you love restoring full arches, you'd love to work, for a practice where that's all you're doing all day, every day. I don't even know how many arches Dr. Polson's doing this month, but it's every single day. I think 2-3 arches are on the schedule. So anyways, if you're looking for that kind of opportunity and you're interested, we're continuing to expand. Our doctors are very well compensated. You're looking at making $600,000-$700,000 plus, as an associate doc working 3 to 4 days a week. So I would say, the first step, if you're interested, would be to reach out to Dr. Sausha. And Sausha, what's the best way for a doc to reach out to you if they are interested in potentially joining our?
Probably through the Instagram.
Through the Instagram, okay.
Instagram, Perio Hero.
Perio Hero,
connected. Yep. I got that name because I thought I was going to make a comic book style Instagram in the early era of Instagram. That's why it's so pompous. and even if you have questions about the digital workflow for full arch implant dentistry, or curious, you got cases, feel free to reach out, and I'll be more than glad to help you out. And like I said, if you're interested in Florida and doing these cool procedures, we have created a nice environment with as much as we're trying to do, we're trying to continuously update the technology too. Like, even though we've come up with the winning recipe, the recipe continues to change. It's the only consistency in our field is change, and we will stay on top of it and incorporate the way we practice in our offices.
Well, why don't you talk a little bit about what our current, workflow is before things change again? So obviously you are helping to onboard our associate doctors as they join our implant practices. You're kind of training them on the technology we're using, as well as best practices for efficiency going through the process. So, let's say it's a standard, hybrid procedure. What does that process look like? What do the steps look like? What's the technology, look like that they're using throughout the process?
Right. So, I mean, patients get in thanks to the team that gets our patients into the door. And then once the patients get in, a cone beam, they normally take a cone beam right out the gate. And so the doctor, I mean, with these full arch cases, your cone beam is going to be one of the most diagnostic instruments you can have. And you can honestly look at that. And I do this for a lot of offices that I work with, and I never even see the patient. They load up a bunch of cone beams, have me look at them, diagnose if they are a candidate. And they walk in and they have that conversation with the patient. And they talk to them, hey, you're a good candidate for having a hybrid, all on X procedure. They then will take an intraoral scan, and one of our doctors does like to make guides, the other doesn't, but you can take the topical scan of the teeth, the intraoral scan, the cone beam, merge them into a software. Blue Sky Bio is one of the free softwares out there that you can use to kind of go in and plan out an implant surgery like that. Or I use 3Shape. I just felt like they're probably one of the most streamlined softwares to be able to plan out an implant surgery. And I make my own guides. And again, that's one of the things I use the 3D printers for. I use them to make my own surgical guides. That's something that labs would definitely ding you for to print them out. And so if you do them consistently, which I do, and I have like a whole spiel on why it's a great way to do implant dentistry, I print out my guides, and then I'm ready for the surgery, essentially. Like if a patient wanted to come in the very next day, I technically have all the things I need. And we do pre-stock a lot of dental implant components because they do a lot of hybrids. So we have a lot of multi-unit abutments, implants of all the different diameters, to be able to say, hey, if you wanted to get this done tomorrow, we have everything ready to do it tomorrow. So once you have the intraoral scan and the cone beam, and you've planned out what implant sizes you want, I'll tell you with full arch, you want to get more than just the sizes you anticipate, because you are going into battle with these cases. I mean, you're talking infections, broken down teeth that are probably going to break facial plate. You don't know what's going to happen during the surgery when you're taking them out, as much as you pre-plan for it. So you're going to have defects to manage that you didn't know you had to. So having different diameters of implants gives you the potential to still maneuver in the surgery and get the job done. So if you just have the sizes you planned in the computer, you are SOL. You need to have more than that. So when you actually go into the surgery, you have the guide. We typically, if we can, sometimes we'll actually put like a pin somewhere in the arch. Sometimes on the upper, we'll put it in the mid palate. On the lower, sometimes in the like posterior region, we'll try to get some kind of pin and either take an intraoral scan or an alginate, just something quick, with those fiduciaries in place. Then you do the surgery. And the goal is never to remove those pins or put those pins back in at the end, because once you take out all the teeth, table the bone, put in a bunch of implants, you're going to have to take another scan at the very end. And that'll come into play in a second. So surgery's done. You got your implants in. On these implants go multi-unit abutments. And honestly, Andrew, do you know what that is? A multi-unit abutment. So multi-unit abutment. The beauty of multi-unit abutments is you can put implants at crazy different angles. Like they don't have to be the straightest thing on an x-ray, and you can correct the angulation of them. So if you have one going like this in this angled direction, and we do this all the time over here because of the sinuses, when you do that to dodge the sinuses, so you don't have to stick something into dead space over there, you will put multi-unit abutments that then correct the angle of the implant, so your access hole isn't coming out the cheek. You correct it because you want the access holes to be as parallel as possible. So you got the multi-unit abutments on, and you want to try to get the multi-unit abutments on. So if you've got to correct an angle of an implant, you got to use multi-unit abutments. So that's a must. People who do full arch, these hybrids without multi-unit abutments, I've seen it. Stop. Multi-unit abutments were designed for this process. So you go ahead and plop on the multi-unit abutments. We do something called grammetry in our offices, because let's say, I told you at the end, we take a full arch scan, an intraoral scan. That has the multi-unit abutments on it. There's no scan bodies on there yet. If you were to take scan bodies and take another intraoral scan, your scan's probably going to be inaccurate. by like 0.5 millimeter. It's going to be inaccurate enough where everything you do from that point on is going to, it might not fail right away, but it's going to fail. It'll end up in my office and I got to fix it. So what you do in these scenarios is you have to have some other way of scanning that makes it super accurate besides just an intraoral scan of the tissue. What we do is something called grammetry. It's these special little scan bodies that go onto the implants, and you lute them together, and then you actually take the device that you've luted together out of the mouth, and then you send the patient home. Or you keep them there and tell them to wait a couple hours till you make the teeth. I've kind of coached my doctors to say, hey, enjoy your life. Tell these patients that they'll get the teeth the next day so that they don't have to, I'll tell you, when you keep the patients there a little bit longer, they get tired just sitting there. They've been there.
They don't want to be there.
It's already a long day. It's a lot of stress to go through. Yep.
Send them where they're comfortable.
Send them home to come back the next day. They'll feel a little better. A lot of times they're groggy because there's some form of sedation involved, oral sedation, IV sedation. I mean, I got some of my patients who are cold turkey, that's real cold turkey right there. Patient sitting in the chair, no sedation, no headphones, just sitting in there. That's worse than a plane ride without headphones.
That's raw dog all on excellent.
Yeah.
We're going to coin a new term. A patient that gets no sedation, no distraction, no headphones, no TV, and sits through surgeries is a raw dog full arch procedure. That's a new thing.
I think that's the next podcast name. Do a podcast with Sausha. That might be the
interview one of these patients. How do they handle their life?
Yeah, we should bring a raw dog patient on here. Like, who are you?
He's like, if I tell you, I have to kill you.
That would be so awesome.
The beauty of this grammetry is this splinted device that you splinted in the mouth is an exact representation in three-dimensional space of where the implants are. But it doesn't have any soft tissue in it, nothing. So when you actually scan that, the lab reads that as just the heads of the implants. That's it.
Oh.
It's just the heads of the implants in three-dimensional space.
It ensures placement alignment.
It ensures that accuracy.
It ensures like 100%, like this thing.
Like 99.999%. Like it's
there's a standard alignment for perfection.
Yeah. The other version of that is something called photogrammetry, which was actually the initial way of doing it. And that's the way I was doing it initially. I have this device. I actually talked to our doctors about buying it. I was like, hey, we're doing well. Let's consider getting one. And they're like, we love our workflow with the grammetry. Like, we don't need it. But photogrammetry is the same thing. You put these special scan bodies on at the time of surgery. Like once you're done, the implants are in. You scan with this. It's a device that there's different devices out there. The one I have is called PIC, P-I-C. It looks like if Wall-E and Eva from the Disney show combined and had a baby, it looks like that. You hold this outside the mouth, 3 seconds, you have your accurate scan of all your implants. All the prosthetic work, like scanning, all that scanning, it eliminates all the other steps that would have had to come to follow afterwards, like impression copings, impression posts, verification jigs. If you know what these words are and you do them daily, or you sweat and you cringe about them a little bit. I hated this. I loved doing this procedure before the digital workflow, except for those steps. As a periodontist, doing all those prosthetic steps, it drove me up the wall. I hated doing it. I hated doing those procedures because of that. I would debate if I wanted to take the patient down that road. But this made it so much easier. I mean, these are all digital scans. Like I said, I do an intraoral scan before, an intraoral scan after, some kind of fiduciary to kind of line them up, and that grammetry scan. And then the patient's gone. And then you send all that. It's a digital file at that point. All three of those files, the before scan, the after scan, intraoral scans, and then your grammetry scan, 3 scans, all sent via an email to your lab technician. Or if you have an in-house designer, I know some doctors actually design themselves. They'll open it up in ExoCAD, 3Shape. There's a bunch of different softwares you can design, and they'll start cranking. The lab that we work with, we have the ability to ask for a 1-hour turnaround. So they will design in an hour.
Wow.
They have a 24-hour, 48-hour. They have different options based on when you're bringing the patient back. They will then email the file back. For us, they're emailing it via ExoCAD. So ExoCAD is what they're using. And then you can see all the different layers, the layer of soft tissue before, the layer of the soft tissue after, where the teeth design came out to be, where obviously where the access holes are. And if you don't like it, again, beauty of having them come the next day, send a quick email right back. Be like, hey, modify this real quick for me. They'll modify it, email it right back within an hour, and then you put it in the printer. We use a sprint rate printer, and we use a resin called Onyx, designed for all Onyx procedures. Prints it in about 30 to 40 minutes. Then we have a washing and drying unit for these 3D printed models because they come out gooey. You put them in the washer. It's an alcohol rinse, rinses it off, and then a drying unit, or a curing unit, which makes it nice and hard. And the Onyx, it's nice because it's a resin material, but it's filled with ceramic. So it makes it extra strong. And so once it comes out of the printer and you've post-process it, sometimes we'll put on pink, like a little pink composite around the gingiva. Sometimes I don't. Because the way I coach my doctors to communicate to the patients about this part, I tell them, hey, the teeth you are getting, they are a cast for healing. You know, when you break an arm, they put you in a cast. They tell you 3 to 4 months, you're not taking this thing off. And your immediate response is, okay, I'm not going to go and start punching people with it, unless you're a football player. I tell them this is a healing cast. Just so happens to look like teeth. Just so they don't run to the nearest steakhouse right away. As much as we advertise the ability to be able to have teeth right away, when you have them in the temporaries, you don't want them going to town on it. They just had surgery. These implants they need to integrate to the bone before you as a doctor, feel comfortable saying, okay, now finally go to Burns Steakhouse and enjoy those teeth. I verb it as that. I say, hey, it's a healing cast. They look like teeth. If they break, you call us right away. If they feel loose, you call us right away. If you're not sure if they're broken or loose, you call us right away. And if they do, immediately that same file, which we have in a folder, not like taking up shelf room in a box, a lab box, in a folder on your desktop, we start printing again because the material cost is minimal.
Yeah.
Reverting back to the days pre-digital, if it breaks, it's a nightmare. I mean, you're gluing it back together and they are just continuously breaking it at the same spot. Or you can ask your lab technician to make another one, another grand out the window. You know, the cost of these things were so much pre-digital and 3D printers.
What percent of these temporaries do you think are breaking? Is it happening on a lot of cases, half the cases, a quarter of the like? Well, if you had a guess, what do you think?
You know, when you do a high volume, you start getting a better feel.
Yeah.
It is a lot more than I would like. It's not. I would say probably somewhere between 50 to 70.
Wow.
Like, I don't have an exact number for you, but a decent amount of them.
So we're almost like preempting the patients. There's a decent chance it's going to break at some point.
Break or get loose. Let me get that wrong. Not break or get loose.
Okay.
Break or get loose.
A complication of some level, 50 to 70.
Yeah, some level that would want me to touch it up. And honestly, sometimes it's just it getting loose. Like when I do deliver these teeth the next day, sometimes maybe there's like some tissue or some grafting material or a suture like in the way, and it feels like it was tight, and it wasn't.
Shifts and it moves.
Right, and then a week later, it's a little mobile. And if I would have let them go 3 months, something would have happened. That would have fallen out. And I'll tighten it up real quick. So we do have them coming back for a quick post-op afterwards just to make sure everything is tied down and tightened. Like even if they don't know it.
So really amazing, right? So digital workflow today. I can come in, bombed out mouth. You do the 3 scans. You send them off. You do the surgery. You take everything out. And then the next day I can come back and at least on a surface level, I can see my smile again for the first time.
Oh, yeah.
I've seen it in years.
I'll tell you, too, they look good.
I've seen the temporary. So honestly, like that and the zirconia, like the end final, like at a glance, you can't really tell.
Yeah.
They look really good.
What's the process look like when the patient is healed and ready to start the final?
So when they're healed and ready to start the final, this is the beauty of the process, too. If the temps were nailed down, like you've put them in and you're like, wow. Midline's on, bite's good, patient's happy. You just tell the lab to make it in zirconia. You take that exact 3D file and send it to a lab to then fabricate it in zirconia. Or if you have your own mill, or your own mills could come into handy. And I know people who do a lot of these also have mills, and that's something that like we're debating at some point is getting our own in-house mill to start milling them ourselves. And that's it. They'll mill it, stain it, and send it back. And, you know, at that point, a patient went from the terrible mouth they had to the final set of teeth, possibly in 4 months. It's possible with this workflow. But there's always some like, okay, the bite's a little off, just a little off. So what we do is at 3 months, 3 to 4 months, once they've healed, that's enough integration time. If everything healed well, I go in, I read tight, make sure everything's still tight, and then if I need to adjust the bite, I adjust the bite. And then I take scans, intraoral scans of the bite, of the prosthesis, and I send that back to the lab technician. And with anything like, oh, hey, move the midline 1 millimeter to the left. If there's an aesthetic issue, I'll take a photo of the patient's face and I will send that with them, and they're able to overlay that also. So they'll put the patient's photo in exocad on top of the digital design. So they'll show you everything, and they'll fix them, and they'll write. And I'll tell you, between 1 or 2 modifications, that's often enough to get you to that final try-in. And the try-ins are pretty quick. You don't have to tell the patient, hey, it's going to be 2 weeks for the lab. Tell the patient, like, hey, you want to come in a few days? You want to come in next week? We'll do another try-in. If it looks good, we'll tell the lab to start working on the zirconia. That's the beauty. Is like I can tell them they're going to have a cast, and they don't have to worry about that being the final set of teeth, because it's so easy to do different try-ins that you can really kind of take your time landing that plane. Whereas back in the day, if you had to do a new try-in, the teeth are set in wax. I'm not sitting there playing with wax all the time. I'd send it back. I was hoping every time it would be perfect because I couldn't manage it. And it would be a 2 to 3 week turnaround to do another try-in. So I wanted to land that plane as fast as possible every time. And I feel like that did result in some of these older hybrids having some potential aesthetic or functional issues because it just took so many steps.
So the multi-unit abutments used in the beginning, at the end when you're doing the adjustments, how is that important for the end when you're doing the adjustments, having that adjustability available?
The multi-unit abutments are these attachments that go into the implants. Have you seen an implant? They got like an internal
implant. I know what the abutment is. Yeah, I own a prosthodontist practice in Texas.
The multi-unit abutments stay on top. They stay on the implant. The goal is to never take those off again.
Never touch them. Okay.
Yeah, and that's kind of the beauty of full arch dentistry, is that it makes the implants matter just a pinch less. Like single unit implant dentistry, what implant you choose sometimes does matter. And there's so many different components that go into that. But for multi-implant dentistry, when you're using multi-unit abutments, you're tying something down in there. They all look the same at the top at that point. They're all designed to kind of, they're almost all of them have a universal system. Thank God for this is finally the first thing in implant dentistry that's almost universal, is everything at the top of the multi-unit is almost compatible with all the systems. And so because of that, it matters a little bit less there. But those multi-unit abutments, they are designed to be there indefinitely. I don't want to say forever because they could become loose and things like that. But ideally, you tighten them down. Now, this is another issue. Back in the day, if your multi-unit abutment did pop loose, sometimes you weren't sure about how to get it back on. Or let's say you wanted to change the angulation. You're like, this axis hole's like coming out the front. It looks stupid. I want to put a multi-unit. But you've already done all your impressions or scans. With grammetry, it's so much easier to modify, so you don't have to send back to all you're doing is changing the angulation, taking a grammetry or photogrammetry scan and sending that to the lab via an email. And again, within a day or two, your files are back. Rather than, hey, let's take a whole new mold, whole new verification jig, send that all back. And that all, not only is it time consuming, that's cost. Yeah. Every time you're doing that you're paying for that. So the digital workflow saves so much on so many different levels.
Digital workflow, one, makes the patient experience shorter, more accurate, better quality of result, better quality of your workday as the practitioner.
Mm-hmm. Yeah, less stress, less hassle.
I like the procedures now.
Like the hassle of the things you disliked were removed. Yeah. As a practitioner, and I'm not you guys, right? But I deal with you guys all day long. So the first thing is we have this procedure that's intimidating, and I have to get over my lack of clinical bravery. Now, if I can make the whole process more enjoyable, I am going to be more apt to push myself and get over that clinical bravery because I don't have all these other things that suck doing it.
Right.
And I have way more control over the quality from beginning to end.
That's why I don't make it like, if you haven't done full implant dentistry and you're trying to work with us, I don't make that a complete no-go, because maybe that's what they were running into and made them fearful of the procedure. And I'm like, look, I'm a periodontist who takes these cases to completion, and they look damn good. And I'm a periodontist. And that means, Matt, just so you know, that means we're not the best at prosthetic dentistry. They don't get to do the final guides. But that's why I ventured into it, because I was like, this made it easy. This made it easier. Now you got, like I said, you got to know all those other technical steps, but this made it so much easier and enjoyable to do for everyone involved.
It's great, man. I often will get dentists reaching out to me asking about our workflow at the implant offices, and I always just kind of shrug, and I'm like, I don't know, man. I can tell you, I can tell you how much our lab bills cost. I can tell you how we get patients in the door, whatever. But like honestly, it only took me about 3 years of us being open to actually learn what our docs are actually doing with these procedures. But it is pretty cool stuff, and I know we didn't start off with our workflow so seamless.
Oh, yeah.
One of the advantages, like we just talked about, is how much easier and more streamlined it is for our doctors and for the patients. But the other advantage is how much we've been able to cut our costs. So, I mean, I think, and honestly, again, guys, like, even though we've had a lot of success, we weren't always doing things right. And when we first opened, Sausha and I didn't realize, I don't think, quite how much our overhead costs were for the procedures we were doing. Until we took a deep dive into it. But unfortunately, the office had already been open for almost a year when we really figured out what our true costs were. And while we collected $1.5 million in our first 12 months, we weren't very profitable because we were very competitive on our price, but our overhead costs were still too high. So,
right. And a part of that too was that we weren't tracking exactly how much of the workflow they were doing.
Right.
So some lab methodologies had changed and I didn't realize it. Yep. And I kind of and that was a part of kind of setting down systems. It's like, okay, this is going to be systematically taught to the doctors coming in. Like, we need to make sure they know this is how it's got to go.
And I think this is true for any office, man. Is like, you've got to have your finger on the pulse. You've got to be involved in the process. And, again, me, because I didn't know how these processes worked and I was just more focused on, the marketing and the payroll and the HR and Sausha, while he was working on making our processes even better, he didn't know exactly what our doc was doing the way he was doing it, and that he was taking some extra steps. So I think there was just a little bit of disconnect going on there. But you have to learn, and don't make the same mistake we do. Don't cost yourself money. Like, learn what it costs to do your procedures so that you understand what your overhead is and what you're charging and what your profit margin is. And always look for ways that you can effectively make your processes even better, even more cost effective without cutting corners. I think, we've had conversations. We've seen, some of these docs that maybe shouldn't be doing implant procedures out there that are cutting some corners to try to get costs down.
The beauty of this is we're cutting costs, but we're actually technically making a better result.
You're cutting costs and increasing overall quality in every aspect.
Correct. Yeah. It's rare to find that come together, but it does.
In all businesses, it's rare, but you've cut costs down to nothing, like really low, but you've increased quality of patient experience, quality of practitioner, quality of workday, quality of the work life, quality of the appliance. Everything has increased dramatically.
I'm one of those docs that, as much as marketing has become important, I never liked the idea that marketing was becoming so important in dentistry, but it's human nature. Like, it's a human nature thing. It's not like hey, it's right or wrong. It's human nature. And these patients, they don't know what they don't know, And so, like, if marketing brings them to the right place, it needs to be done.
Really interesting fact about that. I was on with a practice yesterday, and they're like, we just want to run implant ads. And we've discovered that patients don't know, right? So implant ads, crown ads, and bridge ads. The crown ad produces as many implant patients as the implant ad produces crown patients, because the patient doesn't know. They get to the chair and like, I have a bad tooth and a new tooth solution. You clinically guide them. So we found that groups of ad sets produce a family of a patient type, but not an exact modality of treatment, because the patient has no dental IQ.
Yeah.
Right. Well, yeah. I mean, you have times you see patient on the schedule and they're like, oh yeah, my implant's loose. And you go in and look at their x-rays and there's no implants in their mouth. So there is a limit sometimes to patient IQ. And I mean, to be fair, you don't know what you don't know. I mean, if I'm taking my car in somewhere, I've said this many times, I love to drive cars. I don't know a whole lot about how they work. So if I go in somewhere, I'm going to sound like an idiot trying to explain what I think's going on.
Wow, I didn't know that. Right. First time I met that, I saw his car. I was like, wow, this guy likes cars.
I like driving them. Yeah.
Yeah, gotcha.
Andrew likes fast cars. I like cars I can drive over his car. I've got a big lifted Jeep. Andrew's got a fast car. So we both like cars as different aspects. Well, I'm saying, I'm not about the car, I just drive it.
Have trouble with my QX80, I think. But So, we talked a little bit about lab techs and in-house milling and thing, and it's something you and I have discussed, a few times over the years, Sausha. I think, where our conversation keeps going because of how much we've streamlined our 3D processes and, how much we've controlled costs and how easy and how predictable our product is. I think we haven't hit a point where it's made sense from a financial or
Right.
efficiency standpoint to do either of those things with in-house, zirconia milling.
Correct. Milling is a little bit of a different animal comparatively to 3D printing. And I actually think it would be interesting to like on some maybe like a shorter breakout video, dive into like the specific techs, like 3D printing. Like what's the ROI on that? Like what are those components specifically? Because I just don't want to take up all the time about it. Making a 3D printing apps.
Do a 3-part series on like scanners, printers, and mills.
Right.
They have 3 components. We could do one on each one. It'd be really cool. One thing I want to point out to the audience though is both docs on this call that have built this workflow and systems in these practices. I want to highlight they own these practices. They're never in these practices. Like both of you spend like listen, docs are listening, and docs even talk to me like you're in North Carolina, your practice is in Texas. How does that work? Well, Andrew Vallow inspired that because he never goes to his implant practices, right? So you guys built the workflow, built the process, built the systems, put the right dentist in place. Andrew, how many times have you been in either implant practice? Like 4 or 5 times?
Yeah, I mean, I'd say it's gotten less and less. I used to, before our group grew to the size it is now, I used to go there to run team meetings and things like that more often. But at this point in time, we've kind of beefed up our leadership teams. We've got other people going in. We're doing meetings virtually via Zoom with different small groups and different departments. I really don't have the need to go back there, to those offices nearly as much as I used to. I would say at this point, Sausha and I probably spent more hours in the weeks leading up to opening the implant offices, just getting things ready to go there than we've actually spent in the offices since they've opened. So, we've got great teams there that are kind of leading the day to day, and we're kind of behind the scenes making sure that, Sausha's making sure that our workflow is working effectively, making sure that, the cases are going well. And I'm just making sure that everything is making sense from a business standpoint, that we've got new patients coming in the door, that our, EBITDA margins are good. So it's like, we're doing all that stuff behind the scenes, but you're right. We're not seeing, I mean, Sausha, you've seen a couple patients, over the 3 years at that office, but on one hand, yeah.
Sausha, on what frequency do you go to the practice? Because I'm going to a point here for the docs listening.
Honestly, I enjoy working with the doctors. I even pester them sometimes, like, hey, how you doing? How's everything going? Just to check up on them. I enjoy that aspect. So I try actually, if I do got open up, but honestly, physically in the practice, probably like a handful of times, maybe like 4 or 5 times.
Is doc listening, right? So when docs start going towards these kinds of advanced modalities of treatment, there's a couple different levels of intimidation. One is the procedural intimidation. Next is the business intimidation of how we get the patients and how do we actually. It's one thing to have the ability that you're trained to do something. It's another thing to actually execute and do this as a modality of treatment on a frequency in the practice where it's actual practice, right? And docs are intimidated by both levels, but the two of you have done it, built it, made it work, and removed yourself from it completely, and it's doing, right? So, docs that are listening, if you're intimidated by this, there's different levels. If you're the solo practicing doc and you want to do this in the practice, it can be done because these two did it, removing themselves from the practice. Like, it can be done. Like, it really can. Because I have docs all the time that come to me and go, man, I want to do all, they'll say in their interview with me, I do all on X. And I look at their collections and they do 110,000 a month. I'm like, how many arches do you do? Like, 1, maybe 2 a year, 3.
Yeah.
But you two created multi-arch daily practices and you're not even there, which is pretty remarkable, to be honest.
If you do something 12 times a year, you just don't get to that level too.
Yep.
Yeah.
The repetition builds the clinical foundation of being able to do the process, but also the bravery to be able to do it. And you get better and better every time you do it, right? And those docs, like you said, they get that fear and they're stuck. I think the real reality is you have to get comfortable, and then you have to have the pipeline of patients so that you can actually do the stuff and become actually good at it.
Yeah. I think the biggest challenges are, one, docs aren't willing to invest, either in themselves, for all the training and the technology that they need to do the process well, or they do, and they learn how to do it. But like Sausha said, I mean, you need practice. Like you need to keep doing these procedures to get better and better. And some docs, unfortunately, like they feel like their value is so high that I need to charge this for the arch, otherwise I'm not going to do it. And they're missing out on a ton of cases. You could charge double what we do, but if you're only doing a few cases a year, it's not really a profitable part of your practice. So I think it's kind of getting over that scarcity mindset of like, if I don't get at least this, it's not worth my value. It's not worth my time. My time's more valuable than that, whatever it is. So I think a lot of docs do struggle with that mindset as well. But
And part of it is you just said something really awesome. Is like, if I don't charge this, I don't do it. That's the reality. You don't do it, right? So it's like part of it too is like, you spend the money on the CE to learn how to do it. You buy the cone beam, you buy the motor, you buy all the stuff you need, you buy the scanner, you buy the 3D, you buy all this crap, right? Now you're a few $100,000 possibly in, and like you're trying to hold on to this price point. What you should be doing is trying to do as many arches as you can to cover that giant investment you just made.
Yep.
But the reality is that the dental mentality is backwards. Well, I spent all this, so I deserve top dollar. Hey, doc, if you're listening to this, the patient doesn't care. They care about chairside manner, they care about the end result, and they don't value the thing that you're valuing to overvalue yourself.
Yeah. So guys, this was, one of our longer episodes, but I think really a lot of really good stuff we unpacked here today. Whoa. Sausha, thank you for. Yeah, no, I think you did. We've been
trying, everybody.
for those of you guys that have been paying attention, we've been trying to keep most episodes around 30 to 40 minutes. We know that it can sometimes be tough listening to a long one. So we do try to kind of get right to the point, but I had a lot of stuff that I wanted to, pick Sausha's brain about. So we really appreciate being on here. Guys, if you're still listening, that probably means that you find all this stuff interesting. Like I said earlier, if this is something that you're already doing and you'd like to do it full time, please reach out to Sausha or myself. I mean, like I said, we are continuing to expand our implant dental group. And we are always looking for ambitious docs that just love doing all on X cases, full arch, snapping. So reach out to us. Guys, if you're enjoying the show, as always, please leave us a review. Please follow, subscribe, share with other docs. As we told you before, Matt and I just kind of do this out of the goodness of our hearts. We love to provide valuable content for you guys. It does take a good bit of time to do this, and it really does mean a lot when you guys reach out to us, leave us reviews, things like that. Again, Sausha, great having you on here.
Thank you, guys. Appreciate it. It was fun.
Anything else from you before we wrap up here?
Yeah, guys, please hit like, subscribe, follow, review. Listen, me and Andrew literally do this out of the goodness of our heart. Me and Andrew met with a young doc just a few minutes, honestly, just an hour ago, who we were having a conversation with him on video, and he said, I listened to your Invisalign podcast. I did $30,000 one day party, and he was very thankful for the information. Guys, I promise you this is done with the point of improving the quality of your work life and what you do. And me and Andrew care about that. And I can tell you that when he said that on video, me and Andrew both really felt good about it. That's what matters to us. Guys, if you want to get a hold of Sausha, it's Perio Hero on Instagram, one word. All right. Thank you guys for joining us, and have a great day.